Okay, welcome everyone. I'm Dick Kozarek, the Executive Director of the Digestive Disease Institute at the Virginia Mason Medical Center in Seattle, and we have Dr. Otto Lin, who is the Director of Quality Improvement in the Digestive Disease Institute. We're here today to talk with Dr. Lin about his recently published paper entitled Young Patients with Sporadic Colorectal Adenomas, Current Endoscopic Surveillance Practice and Outcomes. Otto, can you give us some background on why you decided to do this study?
Well, Dick, we've been working with a visiting research scholar from Korea, Dr. Cha, for the past couple of years on a number of projects, one of which was to look at young patients who were at low risk for developing colon cancer. So these are young individuals, younger than 40, who don't have a strong family history of colon cancer. They're really not at risk for having hereditary colorectal cancer syndromes. They don't even have a personal previous history of adenomas. So sometimes these patients, they undergo a diagnostic colonoscopy for one reason or another, and they're incidentally found to have an adenoma or several adenomas, and these are removed. And at that point, sometimes it's unclear what to do with these patients. As you well know, we have very well-established guidelines on how to do surveillance on older patients who are found to have adenomas. We also have very clear guidelines on how to screen young patients who have a strong family history of colon cancer. But for this particular group of patients, the guidelines, I think, are not as clear. It's not completely obvious how to do surveillance on these patients. I think the amount of data that's available in this group is very limited at present.
So tell us about the design of the study.
This was an uncontrolled cohort study where we really tried to select for young patients, younger than 40, who have a low risk for colon cancer in general based on their family history. They generally don't have any strong family history of colon cancer. And for the purposes of this study, a strong family history was defined as either a single first-degree relative who developed colon cancer at an age younger than 50, or multiple first-degree relatives who had colon cancer. So these subjects in our study did not have a strong family history. They also didn't have any personal history of adenomas or colon cancer. They don't fulfill Amsterdam criteria or Bethesda guidelines. So we really focused on these patients, and we had multiple exclusion criteria to try to make sure that the cohort was relatively focused. And then we looked at their medical records, and we looked at the endoscopist surveillance recommendations in these patients, whether or not the surveillance recommendations were adherent to national guideline recommendations. And lastly, we also looked at patient compliance with their surveillance recommendations.
And what did you find?
We had 141, I believe, subjects, of whom 19, about 14%, actually had a moderate family history of colon cancer. So unlike a strong family history, a moderate family history is defined in our study as having only a single first-degree relative who had colon cancer after the age of 50. So those patients were eligible for our study. So when we looked at these patients, we found that 23% of the subjects had so-called high-risk findings on their index colonoscopy. This means that they either had an advanced adenoma that was removed, or 3 or more non-advanced adenomas that were removed. And in this particular group of patients, we found that 43% of these patients were asked to return for repeat colonoscopy in a year, and almost all of them were asked to repeat their colonoscopy within 3 years. Now, the other 77% of subjects were patients with so-called low-risk findings. And of these patients, the study shows that 28% of these patients were asked to return in 3 years. And almost all of them, around 99%, were asked to return in 5 years.
Were these recommendations adherent to the national guidelines, the national recommendations?
Well, if we look at the multi-society task force guidelines, which is applicable not just to young patients, but particularly to older patients, we'll find that the adherence rate was 40% for young patients in our cohort who had high-risk findings, and 68% of those subjects with low-risk findings. Generally, the adherence rates to national guidelines tended to be higher for patients with low-risk findings, but if patients had high-risk findings, or if they had non-polypoid adenomas, or if they had serrated polyps, then the adherence rates were significantly lower. I also wanted to note that the vast majority of patients whose endoscopist surveillance recommendations were not adherent to national guidelines were asked to return too early as opposed to returning too late.
Okay, what else did you find?
Well, there were two other important points. The first one was that whether or not a patient had a moderate family history of colon cancer did not affect the endoscopist surveillance recommendations. The second finding was that the compliance rate for the patient for actually complying with their endoscopist surveillance recommendation is quite poor. And in fact, it was only about 25%. In other words, if patients were asked to come back in 5 years for repeat colonoscopy, only about a quarter of those patients actually did return in 5 years for their repeat colonoscopy.
Otto, what are the strengths of this study compared to the previous literature or previous studies?
There really have not been many previous studies that have looked specifically at this study question. So in some respects, this study is quite unique. I think one of the strengths is that we really tried really hard to isolate a relatively sort of homogeneous group of low-risk young patients who were not at risk for having sort of hidden hereditary colorectal cancer syndromes. So in other words, these patients did not have a strong family history of colon cancer. They didn't have any personal history of adenomas or cancer. They didn't fulfill any of the criteria that are commonly used to detect patients with Lynch syndrome or familial adenomatous polyposis syndrome. So I think that's one of the strengths of the study, and this makes it quite different from some other studies which tend to include a lot of older patients or patients with a strong family history of colon cancer.
There are limitations to the study too, aren't there?
Yeah, definitely. There are several limitations. The first one is that there was no control group of older patients. So we weren't able to do a direct comparison within the study, but we did do the sort of the second best thing, which is we compared our findings with findings from other studies that focused on older patients. The second limitation is that there is a possibility of selection bias because of the retrospective design of the study. And finally, even though most of the colonoscopies done outside of our institution were recorded as scanned documents in our electronic medical records, in some cases, those scanned records might be missing. So there's a possibility that we could underestimate the compliance rate with repeat colonoscopies if they were done outside of the Virginia Mason system.
What's the take home of this message? And as Director of Quality Improvement for DDI, what are we going to be doing in our own institution?
I think there are a few things that we can say from our data. The first one is that generally endoscopists seem to be doing a relatively good job adhering to national guidelines when it comes to surveillance in young, low-risk patients. However, in some cases, especially in those patients with non-polypoid adenomas, there are definitely some situations where they don't follow the guidelines, and this may reflect, I think, a concern that these patients may actually be at higher risk for having colon cancer than what would be obvious just based on their family history. So I think right now the situation is complicated. The guidelines, I think, really focused on people over the age of 50. I don't think they were specifically targeted to very young, low-risk individuals. So at this point, I think many doctors are not completely sure what to do with these patients. The other thing I wanted to mention is that, as I mentioned, patient compliance with their surveillance recommendations was very poor. And many of these patients were asked to come back in 5 years, and only a quarter of them actually came back. So I think this kind of reflects the sort of mentality of younger people because screening for cancer is really not so much on their consciousness, unlike with older folks. So we need to do a better job at improving their compliance because many of these young patients don't see their doctors regularly. As you know, there has been a lot of interest nationally on the increasing incidence of colorectal cancer in young Americans in the last few years. And there's even been some discussion based on the recently updated American Cancer Society recommendations for colon cancer screening on whether we should be lowering our screening age to 45. And our hope is that this data might contribute somewhat to answering this question.
Okay, Otto, thank you very much for all the work and an excellent study.
Thanks.